Natalie Nidham, your host, and we have a fantastic episode for you today. As always, today's conversation is with Dr. Sanjay Bhojraj, who calls himself a curious cardiologist. And trust me, he means it. After decades treating emergencies, he now focuses on prevention, root cause cardiology, and building long-term health rather than chasing short-term crises. In this episode, he shares why most heart attacks don't come from the big, scary blockages you think they do, why stress can be just as dangerous as cholesterol, and how modern imaging like the CLEERLY scan gives us a new, far more accurate window into plaque. We even get into hormone shifts, women's cardiovascular risk, and why cardiologists should probably take perimenopause way more seriously than they currently do. Now, this episode is brought to you by Regenerive, by Timeline MitoPure Urolithin A gummies, and Puri Clean Whey Protein Powder, all with special offers just for you. You got to check the show notes below for those details. But before that, enjoy the show. Dr. Sanjay, welcome to the podcast. Who knew a few months ago that we'd be sitting here?
I mean, thank you so much for having me. And boy, it feels like I've known you forever, even though it's only been just a handful of months, right? So we must be doing something right.
I know. And all we did was share a meal with 8 other people at a very hot table.
Oh, man.
I just remember it being super hot at lunch.
Under the blazing sun. Yeah.
Yeah, in Scottsdale. It's funny that you say that it feels like we've known for each other forever, because you do establish connection with people very quickly sometimes when it's the right fit in person, which I think is it's the beauty of the world being back to an in-person world. There's nothing really replaces human connection in a way.
3 dimensions, so much better than 2 dimensions for sure.
100%. But we'll make do with 2 dimensions here because that's what we've got. We're going to talk heart. I've been wanting to do an episode with a cardiologist like you forever. So I'm that was part of the, I'm like, oh, you would do what? Oh yeah. Yep. No, we need to talk.
There's not a lot of, functional integrative cardiologists on this planet, right? So, and I think it's one of the subspecialties within medicine that needs it the most, because by and large, for the most part, cardiovascular diseases, I feel are avoidable with the proper diet, lifestyle, mindset, mental, emotional, spiritual interventions. But there's just, I think number one, the average cardiologist is just so busy that they don't have time to think outside the box. But number 2 is that it really takes a leap of faith, as with anyone really in this field, to be able to break out and say, you know what, I think there's something more. And that's, in my career as an interventional cardiologist, that was the epiphany that I had was, I can kind of just jump into my origin story here.
That was going to be the next question. So fire away.
I'm by training, I'm what's called an interventional cardiologist. So we are the best type of cardiologist, which are the ones that do cardiac procedures. So I was the heart attack doctor essentially. And so I was the person that you'd meet at 2 a.m, chest pain, heaviness, elephant in my chest, all those symptoms, get an EKG. We'd whisk you away to the cath lab. I'd go in through the artery in your wrist and take a catheter, take pictures of your heart arteries. If there's a blockage, get it opened up. And I was very good at that for a long time. And then one day, I remember one particular weekend, I was on call. And when you're on call, at least in my old practice, you were on from Friday morning to Monday morning. So Friday morning, 8:01 a.m. to Monday morning, 7:59 a.m. Wow. And on that particular Saturday, I had 8 patients come in with back-to-back heart attacks. And you're just running on adrenaline, go. And I had 2 realizations. Number 1 was that, I don't think physically I can do this much longer because of the toll it took on me. I mean, you're literally life or death. You're measured by seconds. You have to get in, you have to open up. Anything can happen. So you're just mentally, physically exhausted. But then, as I mentioned, if diet and lifestyle plays such a huge role in cardiovascular diseases, where are the 1,000 left turns where this person, or right turns where this person went left, or left when they went right? And why aren't we focusing on that, in that vein of an ounce of prevention is worth a pound of cure? And that, in a weird way, led me into functional medicine. And now I run a diet and lifestyle program to help people avoid really cardiovascular risk. And it's not just, statins and beta blockers and medicines, but it's, are you connected to community? Do you feel a sense of purpose? Are you managing your heart? Let's do deep breathing exercises and look at heart rate variability and manage stress and eat the right foods, and healthy foods may be different than healing foods, and just a completely different approach. And in the front half of my career, as I say, I spent, 15, 20 years getting medication lists longer and longer. And now my goal is to make them shorter and shorter, and get people off meds and get people back onto life. So it's really a really different paradigm shift. And why did I do this? I don't know. Like, I sometimes feel stupid and I wish I could go back into the matrix and be happy as I was. But, now that I've seen the outcomes that I've got, there's no way that I could go back, right? Like, I mean, there's no way that I could go back because it's just so powerful. And this is really, I think, what cardiovascular medicine and medicine in general really needs to do, is not just look at numbers, but look at whole people, right? And it sounds like the most obvious thing in the world, but when you're in the trenches as a conventional trained physician, or when you're in there and you've got 7.3 minutes to have a patient encounter, and the average patient is interrupted 7.3 seconds into the visit, it's just not designed for that. So, I'm thankful to be able to step out of the system and actually spend the time with patients and take care of people the way that I think people should be taken care of. So there's a long answer to a question you never asked. How do you like that?
No, but I was going to ask it anyway. I mean, do you ever think about how many people, like, would you have, if there was two of you and one of you who stayed in interventional medicine and the other one who stepped off the merry-go-round like you did, do you think you would have put you out of business?
Meaning would the integrative Sanjay put the interventional Sanjay out of business? No, I don't think so. I mean, I think to a certain extent, the denominator is just so big, right? That unless I can scale myself completely to be able to address everything, but I think there will always be a role, honestly, for both, and I think there needs to be,
for sure.
because if you have an acute heart attack, I'm not going to tell you to do a 4-7-8 breathing exercise, right? That would be nonsense. Like, go in,
no, I don't
get
mean
your
that.
Get your heart reperfused, right? No, but my point being is that we need both sides of the equation, right? And I think of this like in chemistry, there's such a thing as a dynamic equilibrium. If you remember a chemical reaction with an arrow that points both ways, I think sometimes you need to be on the more conventional side. Sometimes you need to be on the more integrative side. But I think that the integrative functional side has really not been pursued, right? So I don't think that everyone's worried about AI and will AI take out cardiologists, and will integrative medicine take out cardiology and regular medicine? No, I don't think so. But I think that it is a necessary complement, because if you are a healer, right, which is different than a doctor, I think, but a healer really interested in healing your patients, healing the people that you take care of, then you have to step out of that conventional models where you're just treating people, right? And really, as we talk about root cause, and I'm doing a talk a little bit later today on reactive oxygen species in the cardiovascular disease pathology spectrum. And it's just amazing because all of these very basic science principles don't really get thought about in the conventional world, right? And so we can affect huge change with diet and lifestyle. But I think there will always, and we've always, we've seen this where you have someone who you think is perfectly healthy that ends up having a heart attack, right? So the more, at least I see it, I call myself the curious cardiologist, because, the more I learn, the more I realize I don't know, right? I mean, it's really fascinating. And so I think I would love to try and get the integrative Sanjay to put the interventional Sanjay out of business, but I think there's room for both of us.
Well, I think that the integrative Sanjay would need to get, I guess I didn't ask my question properly, but I think a better question would be, and it makes a big assumption, right? It makes the assumption that the patient is willing to do the work,
right,
to change their course, right? To, as you said earlier, where did they go left when they maybe should have gone right? And where did they go right where they should have gone left?
Yeah.
And so and this will lead to a second question, actually. So if people followed the program, cleaned up the diet, cleaned up the lifestyle, did the right amount of exercise, not too much, not too little,
right,
the right kind. There's a lot of caveats.
All the things,
here, right? Yeah. Manage the stress. What percentage of people do you think could avoid heart disease?
Yeah, I mean, I don't know that I have a significant like a number that I can point out to you, but I will say this, and we can look at the data from COVID, right? So when we look at COVID and we look at that initial period of the lockdown, presumably people weren't as stressed, they were working from home, all these things. We saw a significant decline. I'd say a 30% decline, at least in my hospital, in our heart attack census, in our stroke census, even in our acute appendicitis census, like people going for acute appies into the OR, they all dropped about 30% or so. And I thought that was super interesting at the time, because to me, that was almost like okay, if we don't have to drive and be late and, do our meetings and not have to deal with coworkers and all this stuff, maybe that's the downshift that we see. Now, you mentioned patients doing all the work. And I think that that's where, we kind of, our mindset needs to shift a little bit, because obviously the conventional system isn't working, right? But I think this is where, number one, returning agency back to patients and reconnecting them with the outcomes of their efforts becomes an issue, right? And so it's difficult to reconnect somebody. If you eat healthy for the next 10 years, you won't have a heart attack, right? It's hard to connect to a negative outcome.
People can barely.
It's a difficult thing to do. But if you can say, you know what, as you eat healthy, watch your blood pressure decline, watch your your energy level improve, watch the number of naps that you take improve, right? That will then reconnect them. And I think this is where really kind of the roles of a healthcare team need to evolve a little bit to involve health coaching, which I think is absolutely fascinating, because now they are that bridge, that link oftentimes between kind of the goal that the doctor has or the healthcare provider has for the patient or client and the effort that a patient or client can put in, right? And how do you match those two? And, I always talk about this. My father-in-law, wonderful guy, I've been married now for 22 years. He's like a second dad to me. And he had a heart bypass 21 years ago. In fact, the year after we got married. And he is now becoming diabetic. And the great advice that he got from his physician was, well, eat less and exercise more. Right. And it's just, and it's just pervasive out there, but talk about completely just not connecting with a patient, right? Eating less. So does that mean that if I eat, one pizza a day and that's all I eat, is that, less than I would normally eat? But is that,
exactly.
Like, do I exercise until I put myself into a heart? Like, what does that mean? Right. So we need to, I think, change the mindset and realize that it's not just putting the onus on the patient, but it's creating a better team, right? And creating a better team to reconnect, shorter outcomes. I mean, I remember a few years ago, I lost my mind and ran a marathon, right? and it was not, I'm not a runner, by the way. I hate running, and every mile I say it was worse than the mile before. So it was just the worst experience of my life.
I'm not sure I believe you.
But
I
did
26 of them.
But and even crazier, that was in the marathon was a training for a half Ironman race that I was running that year. But my point was that I didn't think of, I'm at mile 20, mile marker 1, I've got 25 more to go. I've got at marker 2, 24 more to go. But I was like, let me get to that tree. Let me get to that crack in the street. Let me get to that fan holding that crazy sign. So what I did, right, and this is like an atomic habit, is just make these kind of small changes, these small goals, and then you string them together as a victory and say, hey, wow, before you know it, I'm at mile 13. I can do this, right? Or hey, you know what? Like, I have gone a week, like in my metabolic program, I give people a form to fill out like at the end of the week and say, what was your win for this week? And someone just said, you know what? I didn't have cravings, right? And that's a small win, right? But it's a win, and you string enough of these together and you get that momentum moving, right? And so I think that rather than, I think what we do all the time is blaming the patient, oh, you must be doing something wrong. You must be having dietary indiscretion. You need to exercise more, is creating a team that can foster success, right? And I think that involves much more kind of hands-on than you get seeing a doctor once every 6 months.
Hey folks, I just wanted to throw a little message in here for those of you who are sending me all these incredible questions on social media or through YouTube or even on Spotify, wherever you're listening to the podcast. I wish I could get back to you, each one of you personally, but unfortunately I can't. And because I cannot, I created about a couple of years ago now, I created a membership community where I get to hang out with people just like you. I do live weekly Q&As, almost weekly anyway. We also do have podcast guests come in to answer everybody's questions and do presentations. You get to interact live with those podcast guests. We will sometimes do challenges with some of the partners. Like in 2026, we have a mitochondrial enhancement challenge coming up where we're going to be testing mitochondrial function. We're going to be testing people's deuterium levels. If you haven't heard about deuterium, we've got podcasts coming down the pipes on that. And then people will be invited to follow a personalized protocol and then retest their mitochondria on the other side. We offer that in the membership community, and we do it at incredible discounts that you just can't find anywhere else. So if you're interested in hanging out with me and other like-minded people, which actually happen to include some pretty awesome practitioners and even some previous podcast guests who've come and joined the community, then I invite you to check it out on my website, natnidham.com/the-longevity-community, or just go to natnidham.com and look for the longevity community tab at the top of the page. Click on that and see if this is right for you. I would love to see you there. And we could make 2026 our best year ever together. So once again, that's natnidham.com. Just look for the longevity community tab at the top of the page. Now let's get back to the show. It's walking with them instead of, I mean, on the upside, that cardiologist that told your father-in-law to eat less and move more, at least acknowledge that there was something to be done, because not a lot of cardiologists. I mean, there are plenty of cardiologists out there who wouldn't even have gone that far on the conversation.
I mean, not to say he wasn't right, but he didn't help him. But you need to give people tactical things, right? That's like, like my daughters are in high school, and if I said, "Oh, get a perfect score in the SAT," but I didn't give them like a book to read or a framework or study schedule, right? Like, so we need to chunk it up for patients into smaller bits and pieces. And, there's an old line, how do you eat an elephant? One bite at a time. Right. And so that's what we need to do. Yeah. Poor elephants, and don't eat an elephant because it's just not nice, but
they're just too smart.
but the point being is that, I think we need to shift our mindset in healthcare. And that's where I think that the integrative model makes so much more sense, because we have the time, we build the teams, we have the framework. But we're also dealing with things outside of just numbers, blood pressure, blood glucose, cholesterol, right? Like in the cardiovascular world, to say, hey, you know what? Like one of the best interventions I had on a patient, she came in with palpitations. This is when I was in a conventional model, but training in the functional world. And she came in with palpitations, and I said, she's, when do you get them? And are they related to your cycle? And this, that, and the other. And finally, out of nowhere, I just asked a question, do you feel safe? Right? Like, why would a cardiologist have that? And turns out she was not safe. She was in an abusive relationship and all these things. And that was precipitating her palpitations and her stress and all that stuff. And I certainly didn't have the resources to put her, but I connected her to people that had the resources. And luckily she got better. Right. And so that's the easiest thing to me would have been just to prescribe a beta blocker, which is, I think, what most cardiologists would have done. But this is where, the difference between being a treater and being a healer comes into play. Right. And so I think we just need to have, like a kinder, gentler approach to patient care and be able to give them time and really practice, this precision N of one medicine where, like the person in front of me at 10 o'clock is very different than the person in front of me at 10:30. Right. And so we have to understand the context of where people are coming from, understand, what their exposures are, what their mindset were. And, I'm not saying that I have all the tools for this, but at least I've knit together a network of other professionals that I can send to and say, hey, you know what? It sounds like you're dealing with a ton of little t trauma. Why don't we get you to a trauma specialist that I know so that you can do that? Because until you're emotionally healed, you're not going to be physically healed. Right. And so it's just, I think it's so important, the work that people like us do, because we're really in the business of improving lives, right? Not just improving numbers.
Yeah. Well, helping people to have agency, like you said at the beginning.
Exactly.
So when you made this transition, and even to this day, and we're going to get into the nitty-gritty, just guys, hang in with me, because we're going to go into the CLEERLY scan. We're going to go into CIMT. We're going to talk about blood lipids and LP(a), all the things. But before we go there, how did your colleagues react? And are they sending you people now, or do they have they knocked you off as saying, Dr. Sanjay? Oh yeah, he fell off the edge.
Yeah, they They tend to think I'm a little bit crazy, and I guess maybe they've given up on me because before, at least once a month, I'd get a text from one of my old partners and say, "Hey, when are you coming back? Right? Like, what's going on?"
Aww.
And I think it was just because they didn't want to. They wanted somebody back in the call rotation. They didn't want to be on Q4 call or whatever it was. But I think that when I talk to cardiologists, it's kind of like oh, bless your heart, good for you, but I'm never going to do that, right?
Pat.
Yeah, exactly. And that's cute. And there's always maybe an undercurrent of you're going to wake up one day and realize that you've wasted a few years of your life. And then you're going to come back and hopefully, and this was something the administrators at my job, when I turned in my resignation, said, "Oh, you're going to be begging us for a job in 2 years. And I'm not sure if there's going to be availability." I was like, so what the admin told me, and I said, okay, maybe. This is what I said. I literally said, maybe, but at least I know that I'm on my right path, right? And I'm doing what I want to do. And so, and for me, just like I was saying, like that one, I'm going to run to that crack or that tree or whatever. As I start to accumulate outcomes in clients and patients of mine, that's where I'm like, okay, you know what? I think I'm on the right path here. God is instructing me, the universe, the algorithm, whatever you want to call it, is moving me in the right direction, because I know that I've gotten hundreds of people off of blood pressure medicines, and we have a much more intelligent discussion about the necessity of statin drugs. And I've gotten, hormone balancing and neuroinflammation and all these things that people honestly would have just pinballed around medical specialists for. Like we can just, with a lifestyle and diet kind of approach, I think now I completely believe that about 80% to 90% of the medical things that people present to me with can improve, and can improve significantly. Then the 10 to 20% of the time I have to put my thinking hat on and do some advanced testing and things. But, so yeah, it's definitely been an evolution. I'd lie if I say there weren't days where I'm just like, oh, I wish I could just go back. Life was so much simpler, right? But honestly, I feel like I'm on the right path, and it's almost one of these inevitabilities where you just feel like you're moved by a higher power. I think of it like one of those people movers at the airport. You know what I mean? Where you're walking and the platform is moving or whatever. That's where I feel I'm at right now. Is that even on my worst days, when I'm like, oh my gosh, self-doubt and the devil on one side and the angel on one side. The devil is louder than the angel, but I still feel like as I see people do better, as I help people avoid heart attack and avoid, going back to the cath lab, the cardiac procedure suite, like I just feel like, this is the right thing. And there's 1,000 interventional cardiologists out there practicing interventional cardiology, but there's like 3 interventional cardiologists practicing integrative medicine, right? And this is really the power behind what we should be doing. So it's been an interesting journey for me, for sure.
I'll bet. Well, it's kind of like when and you can't unsee what you've seen. Like all of those cliches apply here. Like, to go back to being an interventional cardiologist right now, I think it would be a struggle. It would be, and it was, towards the end of when I was staying on, because it wasn't like I jumped head first without, trying to create soft landings, but it was a struggle for a while. And I think, that led to burnout. In psychology, they talk about the ought self, who you feel you ought to be and who you are. Right. And so as that split kind of widens, that fueled my burnout quite a bit, until finally I was like, you know what, this is the path that has been chosen for me. In Hinduism, we call it your dharma, right? Your purpose in life. Like your purpose in life is to find and share your purpose in life. It's kind of a crazy thing, right? And I'm like, you know what, this is chapter 3 or chapter 4 or chapter 5 of my book. And the worst plan B I have is I can go back to being a cardiologist one day, but this is really what needs to happen for my continued evolution as a human. So I just kind of, gave myself to the ocean, and we'll see what happens. Love it. Okay. So let's get into some technical stuff here.
Let's go. Let's do it.
Let's talk about scanning, right? Let's talk about the CIMT, which is the cardio-intima medial.
Carotid intima medial thickness.
Yeah, that. And the CLEERLY scan, which is the CAC, right?
Right. Well, CLEERLY is a specialized type of a CT angiogram, which is different than a coronary calcium score. So let's just start.
So let's talk about all 3.
Let's go through all of them. And I'll start with the carotid intimal medial thickness. So CIMT, carotid intimal medial thickness, is looking at one particular layer of the blood vessel. So when we look at a blood vessel, there's got 3 layers. There's what's called the intima, which is the inner lining, the media, which is the middle, and the adventitious, adventitia, which is on the outside. The adventitia, easiest. It's mostly the connective tissue. It's the stuff that makes vessels rubbery and being able to kind of expand and contract. When you feel your pulse pulsing, that pulse is as a result of the strength of that. We want, you definitely want pulses. You definitely want that.
No, I mean, like you want the flexibility.
You want sponginess,
is that
right?
What stiffens with age?
Yeah. Well, stiffening, we can talk about stiffening, I think, but yeah, because there's a neurohormonal part of stiffening and then there's a mechanical part of stiffening, both. So on the outside is, let's just say, the elastic component. On the middle, that's really kind of the meat and potatoes. That's where you have a lot of the cells circulating, vascular smooth muscle cells and dendritic cells and immune cells and modulators. And that's where foam cells kind of come in and form atherosclerosis. And there's the intima, which is kind of the barrier. It's kind of like the skin of the blood vessel that's layered on top by something called endothelium, which is a single cell layer thick group of cells. And I kind of think of it like old shag carpeting on the inside. Anyway, a lot of detail.
Good shag carpeting, not the nasty.
Yeah, it's like that fun stuff that I had in my house growing up. So when we talk about carotid intimal medial thickness, as I mentioned, the media is kind of like, I consider it like the workhorse of the blood vessel in terms of the active biology where it happens. And so that's where you can get thickening, plaque formation starts, all of these things. So when we look at a carotid intimal medial thickness, we're doing an ultrasound of the carotid artery. The carotid artery sits in the neck. Whenever you watch a detective show and they check if they push on someone's neck to check if they're alive, right? That's the carotid. Just as a quick safety public service announcement, never measure both carotids at the same time. You'll pass out, right? So one at a time. Just, I always put that out there.
And don't use your thumb, because you'll measure your own.
When you're measuring on somebody else, because you have a pretty significant vasculature in your thumb. So anyway, CIMT is looking with ultrasound at the carotid artery and getting a measure of the thickness then assessing as a surrogate of plaque, because you can't tell the difference, but there are associations with an increased CIMT and atherosclerosis. And remember, that process of plaque formation, what we call atherosclerosis, is non-prejudiced. It happens everywhere, right? There was an old, I think it was a W.C. Fields line, "I'm not prejudiced, I hate everybody the same," right? So that's what I say about atherosclerosis, is that if it's happening in one territory, it's very likely it's happening in others. And in fact, the literature shows it's about a 1.6 to 3-fold increase in coronary risk if you have a CIMT. So they're not 100% correlated, but it stands to reason if you have plaque in your carotids, you're probably going to have something building in your heart.
How much plaque is significant?
So when we talk about significance in the interventional world, what we're really worried about is flow disruption. So I've got 3 daughters who will have long Indian hair. And so I say there's always some amount of hair in their shower drain. But when it gets to a certain critical mass, then the water starts to back up and I have to go snake the drain out, right? So in the arteries, that flow limitation happens around 70%. That's when you start to see kind of a reduction of flow and a pressure drop, which is what we'd look for across the vasculature. So that is, what's considered quote unquote significant when we look at coronary arteries for stenting or whatever, like peripheral vascular, renal arteries, wherever I used to put stents in. 70 is kind of that benchmark, is that metric. But what gets hidden behind that is that when we look at the blockages from 20 to 50%, these are less mature. So they have what's called a thin fibrous cap. These are the ones that are likely to rupture. These are the ones that are really just metabolically angry on the inside and they have a lot of inflammation in them. So those are the ones that will cause acute cardiac events. And so this is where a lot of times we see some discrepancy in testing, and we'll get back to calcium scores and all this stuff, I promise, in a moment, but I think it's a good point.
But is that, really,
we've heard of, like, oh, did you hear about, Bob, right? I'm sorry if anybody out there is named Bob, right? I hate to put that out there, but Bob had a normal stress test on Monday and then had a heart attack on Tuesday, right? And so heart attacks must be caused by stress test, right? We try to find these correlations. No, but what happened was Bob probably had a 30% or 40% plaque that was not flow limiting. Ergo, therefore, you wouldn't see it on a stress test, because stress tests are really only geared towards finding those flow limiting tests. But because it's the 20, 30, 40%, 50% lesions that are less mature and rupture, the hemodynamic stress, the shear stress on that cap probably unroofed it. And that led to his heart attack, right? So
okay, question before you keep going. So if Bob is an athlete,
is
he more likely to have an event?
Well, so that's in an acute setting, generally of like a couch potato type person that
No,
like
yeah, so
like the weekend warriors where you see this a lot. I always I live in Southern California and I'm always nervous about the first gorgeous SoCal weekend because that means that people and it's like when I trained in Michigan and we always worry about the first snowfall because you have people who are not doing anything for a long time. They're going out and shoveling snow, which is a very physically demanding thing. Here in SoCal, I'd have people go out surfing or do endurance cycling that they weren't accustomed to doing. And that was a huge hemodynamic stress on their cardiovascular system that led to then this event happening, right? So chronic athletes are a little bit different. So endurance athletes, and I used to see a fair number of endurance athletes in my triathlon days. So we have this, but there are adaptive changes that can happen. So your body gets more accustomed to these forces of nature, these hemodynamic things that happen. Interestingly, though, they are not immortal. Is that you can see premature coronary calcification in endurance athletes. You can see left atrial stretch, so increasing in size of the chambers as a result of what we call in the cardiovascular universe excessive endurance training, and in a lot EET it's called, and in a lot of the literature that's described as running more than 25 miles per week. Now, if you're a runner or an athlete, 25 miles is, for me right now, not something I would do, but it's not that much. And of course, different sports are different, right? Cycling is a different hemodynamic stress load than running or swimming, just to put it in the triathlon days. So we're learning a lot about these athletic events and athletic endeavors rather and how they may differ. But just because you're a long-term athlete, you may be subject to other stresses that a couch potato wouldn't be, right? So nobody is safe, but that's why everybody needs to know their risk. And that's why everybody needs to know their numbers and know their anatomy.
Okay, another question for you is I have heard, and because I'm just going to go, because I have a bunch of people in a community, so all these questions are bouncing around and I don't have the answers. And I'm like, I'm interviewing a guy, I'm getting the answers. Yeah. So if somebody has a CIMT score, let's say it's 23 or 24 or 25% or 30%, does that necessarily represent plaque, or could the thickening of the wall be due to something else?
Generally it's going to be some sort of atherosclerotic process most of the time. Okay. You can have medial hyperplasia from other, like, trauma can cause it. I had one guy who was a surfer that took a surfboard to the neck and that caused a huge inflammatory response. But generally speaking, when we're looking at CIMT, I would say, it's plaque. And
if it's bilateral, it's going to be plaque.
And if it's bilateral, generally, nature loves symmetry, right? So generally you're going to see it on one side or the other. That being said, the aorta, the way the vessels come off the aorta are not symmetrical. So generally speaking, on the right side, you've got what's called the brachiocephalic trunk that then splits into the carotid and the left and the right subclavian. On the right side, each has a different, or on the left side rather, they have a different takeoff, each one. So the carotid has its own origin and the left subclavian has its own origin. And that is to say that when we see vascular disruption or plaque, it generally is at what we call a bifurcation point or a fork in the road, because that's where the currents of blood flow get a little bit more chaotic and you've got pressure drops and things like that. So it's generally going to be at a bifurcation or a split in flow that we'll see these plaques and things develop. But if it's bilateral, generally that's going to be atherosclerotic. And that's not to say it has to be pretty significant trauma to see kind of a vascular response, not just like wearing a tie to work, for 40 years, right? That
shirt that's too tight.
It's like, if you took a seatbelt, and like a seatbelt in a car accident or something, that's the sort of stuff we're talking about. Yeah. Just to hop back though, to complete our discussion. So CIMT, ultrasound based, I think the strength of that is that it's non-ionizing radiation, right? So it's ultrasound. And so we're able to see, thankfully, the carotid is an easy enough vascular distribution to access that it gives us a good proxy. And I think that's why it's been pretty established as a potential screening tool. And I know there are a lot of people in their offices will have CIMT measurements, and there's automated scans that can be done. So there's that. Then there's coronary calcium score. So when you have a plaque in your artery that heals, I kind of think of this like you've got this angry mass of plaque and the body says, you know what, I recognize something is going on. I don't want this angry hot mess to digest through the artery, which is essentially what's happening, is that you're secreting, and these inflammation gone bad cells are secreting enzyme foam cells, and macrophages are just inflamed, angry, heated messes. And you have to build a wall around the prisoners, so to speak. And so that's a healing response. It's called epithelial to mesenchymal transformation, EMT, where these circulating stem cells inside the media of the blood vessel actually transform from stem cells into similar cells to the ones that create bone, to osteoblasts. And so now they kind of build this shell of calcium in three-dimensional space around that angry plaque. And that's actually healing. That's considered plaque healing.
Just like stabilizing the plaque.
Stabilizing the unstable area. And so when we do a carotid artery, a coronary calcium score, you're measuring, there's a unit called an Agatston unit. So you're measuring in how many units of calcium you have in the arteries. And that was a great tool back in the 1980s and 90s to be used to establish, at a low level of radiation. So it is a CT scan. So there is X-ray involved, but it's a lower level than most scans. In your arteries, this is what we see. And so the power of that is I can say, again, let's go back to Bob, Bob, in your artery, the widowmaker, has plaque in it, and the left artery has this and the right artery has this. So, you can use that. We're talking about agency and motivating patients. You can say, so this is what your heart looks like, dude. We need to be aggressive about fixing things and this, that, and the other, right? And we need to be aggressive about getting you on meds and diet and lifestyle and all of these things. And so it was a really great scan. And I say it was a great scan because I think at the time that it came out, it was pretty revolutionary. Papers were written about it. Scanners popped up all over the universe. But now it's almost like a black and white television relative to the next generation of scanning that we have, which are these coronary CT scans. Now, a coronary CT is a dedicated CAT scan of the arteries that allows us to image the heart arteries themselves. And so now we're not just saying you have calcium, but we can say, oh, you've got a narrowing here of 30% or 20% or 50% or whatever in a traditional CT angiogram, which is what became very popular. And the cool thing about that is now that gives us insight not into what's just called the lumen, which is the opening of the blood vessel where the water flows in the pipe, so to speak, but we can actually, which is what we see on a conventional angiogram, which is the test where I go in and take pictures of the arteries. But now we can get an assessment of the vessel itself. And if there's thickening of the vessel, which is not something that you can see on a calcium score, nor can you really see that on a conventional angiogram. And now we've taken that one step further with this AI technology called CLEERLY, CLEERLY, which is, I think, the one test that as cardiologists we've needed, or not just as humans, right, that we've needed forever, because now not only are we seeing the calcified plaque, which is important, but in the mind of an interventional cardiologist, a little bit less important because it's less likely to rupture. But what we can do is quantify the soft plaque, and we can actually see, how much plaque do you have? Where is it located? Is it all in one spot? And I think of it like a balloon where, you can almost look at the wall tension of the balloon and eventually it'll rupture, right? Well, you can look at plaque size, and you can look at lesion size, and you can look at, calcification, like where it is in the spectrum, and you can assess, how significant it is. And this is what a lot of people don't understand about calcium scores. You can have a 0 calcium score and still have a ton of plaque, right? Because the plaque could just be non-calcified. It could be what we call quote unquote soft plaque. So now with a scan like CLEERLY, you're not only getting an assessment of calcium, which again, I would posit is less important, but more importantly, we're able to quantify the amount of soft plaque, get an idea of vascular health, and now engage in either, conventional medical approaches or diet and lifestyle approaches. And we can actually see regression of the soft plaque, which I think is the important actionable part, right? Is that through aggressive diet and lifestyle interventions, through, for people who need them, and not everybody needs them, but for people who need them, cholesterol modifying medications, you can actually see an improvement. And this is where, when we talk about cardiovascular medicine and longevity medicine, I say cardiologists are like the OG longevity medicine docs, because most people die of heart events, right? Of cardiac events. So if you are stopping cardiac events, by definition, you're going to improve longevity, right? And so now we then can talk about, once you've talked about longevity, then you can talk about health span and making days better and kind of all of this stuff, right? So this is, I think, a revolution in testing that I love. Now, the downside to it is that, you do need to have what's called IV contrast infused. So you have to get an IV, and they have to put an iodinated contrast in you. And so for some people, you can have a reaction to that. For some people, if you have kind of poor kidney function that can affect you. And there is a lot more x-ray. There's a lot more radiation, right? So this isn't a test that you're going to want to have once a year, right? I mean, I think that there are guidelines on this depending on, the amount of plaque that you have and the distribution, when to repeat a study. But I definitely think as an initial scan, the bark is worth the bite here, is that, just to be able to get a better insight is so much better. And I had a patient. So I recently implemented this. I recently started a telehealth practice. And so I've got patients. And so I recently had a patient who on the outside, he was, he's probably about 150 to 200 pounds overweight, was telling me, I have symptoms when I walk up a flight of stairs, I get really short of breath and I'm having a hard time, with breathing and activity and all these things. And in my mind, I'm prepping for the heart bypass talk. And a lot of patients might not realize that it's very emotionally disturbing for a cardiologist to have, or at least for me to have that talk. It's an upheaval for me, right? Like, because I become friends with my patients and I don't want anything bad to happen. And so to have that talk is quite emotionally draining. And so I said, all right, but let's call him Fred. His name's not Fred, but we got Bob and Fred. So Fred, let's get a CLEERLY test for you. And so I can better define the anatomy. And again, this is a guy who on the outside, looks like the poster child for cardiovascular disease.
Right.
And we did the scan, and lo and behold, on the inside, he had like a 14% lesion in one of his arteries and everything else looked okay. And I was like, wow, that's amazing. Now I can just focus on your blood pressure and focus on your cardiometabolics and plug you into the diet lifestyle program and really see some change. But, it really gave me such like the opposite insight that I thought. I thought I'd learned how bad his heart was, but instead I learned how good his heart was. And that was very optimistic for him, right? Kind of changed his mindset. So he's like, wow, now I don't need to be so scared. That's not to say I don't need to change, but that fear of God kind of left him. Now he became motivated and positive to say, hey, you know what? This was, this scared me. This was my awakening. Now I can really work on diet lifestyle with you, Dr. B, and get things moving. And he's done great. Right. So, you don't judge a book by a cover. Similarly, like with cardiovascular disease, I've been humbled so many times by stories like this, where I think, oh, someone's actually going to be okay and they end up needing bypass, or I think someone's going to need bypass or stenting and they don't. So it's another great tool to not just look at your risk today, but also then to stratify what your risk looks like 5-10 years down the line, so that we can do appropriate diet and lifestyle interventions that are based in science and have some credence, not some crazy nonsense trend or fad or whatever the new Instagram, TikTok reel is, right? But do things that can actually have effect and make a difference.
So you had said earlier that the CIMT bears some relationship to what's happening in the heart, but it's not a direct relationship. Conversely, for someone like that who had a pretty CLEERLY scan, you would be able to extrapolate that to carotid arteries, or would you also be doing a CIMT at that point? Because is it possible that he wasn't... somewhere else?
Yeah, I need to look at the reason for the outcome, right? If he was having neurologic symptoms, then I would have probably just gone straight to carotid, but really we're looking through cardiovascular. And again, he's got a 14% lesion, right? He doesn't have nothing. He just doesn't have like eyes popping out of my head, like in the cartoons findings, right? So, I think that, because he presented with cardiovascular symptoms, that's why I went straight to a cardiac test, because really, like I said, on the outside, listening to the story, I was worried about, the bypass. And in fact, I wanted him to get an angiogram, but he insisted on the CLEERLY. So I said, okay, but just because I was able to schedule him quickly. But if someone comes in like what we call a primary prevention patient, my dad had a heart attack at 52. I'm 48. I just want to make sure I'm okay. I run, I exercise, I go to temple, I read to blind kids. I do everything good in life, and I just want to get a sense of what's going on. Then I might start with a less invasive test. I tend to not want to irradiate people, and particularly women, because you're irradiating the chest area and breast tissue is sensitive. So I really use x-ray sparingly, but that's where I'm saying sometimes the bark is worth the bite, right? Or the bite is worth the bark, or whatever. Is that sometimes you just kind of push through the risks because you know that you're going to get such important information. For Fred, it was such a great example of, going to having the right technology for the right test, so that I could connect him with the best plan to move forward.
Is there an age you think that like in many different things, different aspects of health, it can be helpful to have a baseline from when you're healthy, not wait till you have symptoms or you're sick.
Right.
Is there an age where you think that probably for most people, it would be a good idea to get that CLEERLY scan done to get a baseline and then leave it alone? Like if it's clean.
Yeah. And then shelve it for a while. Yeah, I mean, I think that when we look at longevity, right, in the longevity space, there's two ages that kind of pop out in the literature: 44 and 60. Right, these are 2 years where we just see kind of big shifts, and so I think right around then, and if you think about the average life expectancy in the United States, I think I looked it up a few days ago, is 79.2 years. So
it's pretty low.
Yeah, so middle age is like 39. Right? I mean, so that's kind of sobering. Sorry for the listeners, but that's just numbers, right? That's the math is mathing here. So I think, maybe not necessarily a scan, but certainly a clinical evaluation around 45. I think it's a great 45th birthday. In fact, that was the first time I went to see a doctor for me. And when I kind of made my own life changes, was I kind of felt like 45 was the official birthday of more yesterdays than tomorrow's, right? So I said, I need to kind of take my health serious now. And for a lot of people, right, in the world, that's where you're like mid-career, you're maxing out your earning potential, you've got your family, you've got your kids, you're doing all these things. So that's also kind of a time where you stand to have the most to lose, right? If something bad were to happen. So for me, I loved getting the patient in their mid 40s as a cardiologist that says, you know what, nothing is wrong, but I want to keep things moving, right? And I want to keep things going. And that's where you can do things like, you don't necessarily have to jump to a scan. I think a carotid is a great test in that sort of a population, but doing things like, I don't even call them advanced lipids anymore, but comprehensive lipids, doing a cardiometabolic analysis, looking at LP(a), looking at markers of vascular inflammation. I think that's where that kind of well exam kind of comes into play, because if you can make those little 1 or 2% lifestyle changes at 45, then 65 is going to look a whole lot different for you than it would otherwise if you'd stayed on the path that you were on, right? So I like those mid 40s patients to come in and say, you know what, I want to live forever. I mean, not live forever, right? But I want to live like really well. What do I need to do? And I think that's a great time. And then, with those patients, I might see them once every other year, once every 3 years, but keeping them on that straight and narrow path, because I think that's one of the main differences between the conventional model and the functional model, right? Is the conventional model says, we're not going to see you until you're broken. Right?
Yeah, no, 100%.
We're gonna just be 100% crisis management, and that was when I saw a lot of patients come in their 50s with heart attack, and mostly guys, and I'd say, when was the last time you saw a doctor? And they'd be like, oh, when I got my high school football physical filled out, right? I mean, there was like a long time in between. So I loved getting those kind of patients, and you might not do a lot of interventions in the sense of balloons and stents and things, but you can keep people on the proper path. And integrative Sanjay can put interventional Sanjay out of business that way. But that's just the smarter way to approach this.
What about women? Because when women go through menopause, things start to shift. All of a sudden, we get a lot closer to being small men than premenopause, right?
Yeah.
Like our cardiovascular disease risk goes up. And are you making a distinction? Because you mentioned hormones earlier. Would you make a distinction between a woman who is, and we don't need to argue the benefits or, whether people should or shouldn't do hormone replacement.
Yeah.
But I would imagine there's a distinction between the woman who's on hormone replacement and the woman who isn't.
Oh, for sure.
So would we add maybe another goalpost for women post menopause to see where they're at? Because things can shift pretty fast.
Well, and I think post menopause is even a little bit later than I'd like. And premenopause or perimenopause, which is a very difficult time to define unless you're a cardiologist, because we see this all the time, right? You get your labs done, and your LDL, which was at 80 forever, bounces up to 100. Right.
Yeah.
And the primary care doc, or if you're seeing a cardiologist, says, oh, you must be doing something differently. You must be having some dietary indiscretion, or you must be exercising more. But really, when you see that jump to go from 80 to 100 is a 25% increase, right? If my math is right. And really what we're seeing there is not, the only thing you're doing is not forming enough estrogen. So you get that. I mean, you get this. I know. How dare you, right? How dare you? And so when you see that initial estrogen drop, that is part of the pre-menopause, you see this LDL bump. And as I look back in time, you always facepalm about, oh my gosh, all the things I wish I knew then that I didn't know now. But that's, I think, one of the earliest signs of premenopause is that LDL bump that we see. It's almost never enough to elicit therapy. Like, it's never enough where I would say conventional Sanjay would say, oh, you know what, you need to go on a statin for this. But it's enough that you see a percentage jump. And so that's the time when, and this is where conventional cardiologists, probably there might be one on earth that would do this, need to have the discussion with these perimenopausal, premenopausal women about, now might be the time to start doing comprehensive hormone panels and potentially adding in estrogen, because as I see it, and I've had several, talks with hormone people, is that estrogen is as important for, hot flashes and all that crap. Yeah, there's some benefit to that. But when you look at bone health or cardiovascular health, right, it becomes hugely important. Estrogen is protective against cardiovascular events. And so that's why, as you mentioned, as you see that drop off in estrogen, women become little men, meaning that their cardiovascular risk jumps up precipitously because they don't no longer have that protective effect of estrogen. And so we were, right at the front line of seeing this. And I just didn't know how to read the tea leaves correctly there. Was, right when that happens, you're like, okay, you know what? Let's either meet with an OBGYN or someone who's like a BHRT specialist or something who can start to have that discussion. And you're going to see so much improvement, not just in cardiovascular outcomes, hypertension, lipids, atherosclerosis, all of these things, but, bone health and longevity and brain health. I mean, every receptor in the body every cell in the body has sex hormone receptors, right? Essentially, with the exception of maybe red blood cells. But these are important things for longevity, but also for health span as well. And so, I think cardiologists have been frontline unknowingly, at that transition without realizing that it was within our power to interpret this and act on it.
Yeah. Well, you would hope that somewhere someone is listening who runs a school like the cardiology program and is saying, holy shit, we need another module.
Yeah. I mean,
we need a module for women, for your women patients who are coming up. But this is the thing. If you weren't taught it in school,
we're all victims of our training, right? And when you look at historically in the cardiovascular literature, I mean, there's just famously, I think it's so funny, is that probably about a year and a half, 2 years ago now, in the Journal of the American College of Cardiology, they had a review article about the differential effect of stress in women. And it was like the first time that they acknowledged that women are different than men, in cardiology. And now you're looking at cardiovascular trials, they're including more women and all of these things. But when you look at all the data, all the science that our current fund of knowledge in the conventional world is based on, those trials were like 80%, if not more, men, right? Oh, yeah. And I mean, I hate to say it this way, but women aren't just men without penises, right? Or whatever, no. like it's a completely different physiology. And so, this whole realm of, and if you talk to old crotchety cardiologists, they will still to this day say, oh, why do we need women's cardiologists? Women are the same as men. And I'm like, no, they're not. Like they're so different, dude. Like, come on, are you serious? Like,
but the reason why women were excluded from research is because they're so different from men. Otherwise, they wouldn't have been excluded.
Yeah,
you have 4 different women a month,
and it's so complex, right? And if you talk about the life cycle of a woman, there's pubertal, fertility age, premenopausal, perimenopausal, menopausal, postmenopausal. I mean, it's a wild ride to be a woman, right? But I mean, we
know that because you're surrounded by them.
I've got 3 daughters and my wife, so I have a front line to this all the time. But we need to, I think, look at hormones a little bit differently. And I think of it like vitamin D, right? Like vitamin D, you have a low level, so we supplement it for the potential health benefits, bone health and hormone health, and all of these things. Similarly with estrogen, I think there is still this WHI, Women's Health Initiative cloud that hangs over that says, unless you're having really bad symptoms of hot flashes or whatever, there's no reason for hormone replacement. But in fact, with vitamin D, you're treating a number for all these other benefits, right? So if your estrogen is low and you're already seeing an LDL bump, well, the easiest way to treat that LDL bump is to give back some estrogen, right? And there's all these other health benefits, brain health, bone health. I mean, you can probably talk my ear off about all of these things, right? Mm-hmm. And so we have to frame that conversation differently, frame the mindset of cardiologists differently, and realize that, again, we are front line to a battle that we didn't even realize we were at the front lines of. But we also have such a powerful ability to heal. And, and that's why, I'm working with some other cardiologists to create like a functional cardiology curriculum and training pathway, because, we see these things and we need them. And I think of all of course, to a hammer, all the world looks like nails. So to a cardiologist, I'm saying, boy, the single specialty that I think would really move the needle the most for humanity if we had a more functional mindset is cardiovascular disease, right? Is cardiology. Mm-hmm. So anyway,
I love it.
That might just be me justifying my own existence. I don't know.
No, I think it's me. I was hoping you were going to say at some point that you were going to be spreading this wealth of knowledge to other people in the field. So let's talk about another topic that is wildly controversial. I mean, there's so many of them, right? But let's talk about cholesterol.
Yeah.
Because right? Yeah. So the cholesterol is bad versus not only do you need cholesterol, but there's no high cholesterol numbers that are bad enough that you should ever need a statin for. Yeah. And like there's these, the world
there's these camps. All over the place. These polarizing, air is good, air is bad, fire is good, fire is bad, right? Like, so number one, right? Cholesterol is a necessary molecule for existence. Hormone backbone, cell membranes, all of these things. Brain, all of these things. Number two, the majority of your cells have the ability to synthesize their own cholesterol when needed, right? So circulating cholesterol and cellular health, I think, are two different things, right?
Okay.
Three, and this is what I think a lot of cardiologists don't realize, or they don't see things correctly, is when we look at the contribution of dietary cholesterol, meaning if I eat 1,000 eggs, right, how high does my cholesterol bump? It's actually not that much. And in fact, it's in the evidence, right, in the literature, now they're saying it's not a big contributor. So I say, okay, if diet, which we took as the major reason for why cholesterol was elevated, right? If diet is taken out of the equation, why do we have high cholesterol at all? Mm-hmm. Right? Like if people are eating low cholesterol diets and things or I mean, even if they're not eating low cholesterol diets, if we are literally saying to people, it doesn't matter what you eat for your cholesterol, why is LDL elevating? Right. And this is where I think the conventional world is right for the wrong reasons. I think that LDL, so to be clear, cholesterol is a sterile molecule. It's not soluble in water. So it would be like a little oil bubble floating on top of a glass, right? Of oil and water. So what do you need? You need particles like school buses to shuttle them around. And that's really what LDL is, low density lipoprotein. And on the vehicle, you have these little receptors, and one is called ApoB, which a lot of people are getting more familiar with. And that's like the sticker on the car that says Ford or Toyota or whatever. It tells you that this is an atherogenic particle, a particle that can cause cholesterol synthesis, right? Or cholesterol plaque formation. And so you have ApoB receptors and LDL receptors on various cells. And the reason that cholesterol gets transported around is that the cholesterol is generally supposed to be incorporated into the cell membranes. But you have so much cholesterol, right, that it gets taken in, and then you have it gets damaged by reactive oxygen species and becomes oxidized and then forms plaque and all this stuff, right? So in my mind, I think that there is little doubt that elevated LDL is associated with cardiovascular disease, right? That's just there. Now,
I'm going to stop you right there. Hang on. Because before you go on, there's another conversation about VLDL and oxidized VLDL, and there's big fluffy LDL and little bitty LDL. Just because before you keep going, I know.
So there's types of LDL, and this is where advanced lipid, or I call it just comprehensive lipid panels, can be helpful because we get a sense of LDL particle size. And so I call them big and bouncies and small and stickies. So you can have big bouncy LDLs, large buoyant LDL particles that are less atherogenic. And then you can have small dense LDL, which I am blessed to have myself. I've got the smallest LDL particles I've ever seen. And those are the ones that are more atherogenic. And the question is then why? And this is again where cardiology is right for the wrong reasons, is that, when we look at particle size, when you get these small dense LDLs, that tends to happen in people that have cardiometabolic dysfunction, people who are insulin resistant, all of these things. You get these small particles that are more easily oxidized. Oxidized is rusted, basically, or damaged. And what does your body do with damaged cells? Well, it tries to get them out of circulation, right? So it pulls them out of the blood into the cell. And unfortunately, when it happens in the arteries, into the media, where it forms a foam cell and plaque and all of these things. So oxidized LDL is, I think, a very important metric to kind of look at, not just for the state of what your cholesterol is, but also the state of your reactive oxygen species and what the redox status is and what the imbalance looks like there, right? So you're damaging these LDL particles, you're turning them into DAMPs, right? Damage associated molecular patterns, and you're activating the immune system. And atherosclerosis is an immune mediated process, right? So we have these now advanced metrics that you can check: oxidized LDL, oxidized phospholipids. Even oxidized LP(a) is something that I've seen described now in the literature. And what that does is it takes a bad thing and makes it really, really bad, right? And LDL, why do we focus so much on LDL? Because in the 80s, that's what we could calculate, right? But there are total cholesterol particles. They're what are called HDL, high density lipoproteins. They're quote unquote good cholesterol. They're like the cholesterol scavengers. And then you have this entire population of LDL, which is low density. You have VLDL, very low density, IDL, intermediate density lipoproteins. And all of these are atherogenic. We just in the 80s didn't know that they existed. And so they didn't become part of the standard panel being total cholesterol, HDL, LDL, and triglycerides. So then there is this metric now of non-HDL cholesterol that was assessed. And essentially that's, in my mind, kind of very congruent to what we think of ApoB. Cholesterol. ApoB, as I mentioned, is like a cell surface protein. It's like a marker that sits, because you can't just look under a microscope and it says LDL and HDL on there, right? You have to look at the tags that it has on the cell surface. So when you have an ApoB particle, that means that it is one of these atherogenic particles. And so it kind of more completely describes the entire pool of lipid particles, lipid transport particles that can be linked to atherosclerosis. And some people, if you have familial issues or genetic types of hyperlipidemias, you can actually have low LDL and high IDL in the way that the biochemistry works. So an LDL is an imperfect assessment. So you really want to look at either non-HDL, which most commercial labs will run, or ApoB, which is a test that you can run, costs about maybe $10 or $15 to get a sense of what's going on. Right? Did we exhaust the LDL talk?
So in this day and age, if you're sitting with your cardiologist, you want to kind of push them a little bit and say, but can we look beyond just the LDL number, right, or is the LDL number enough?
Like, no. I think that it is.
Act on fluffy LDL the way you do on the oxidized.
Exactly. And so I think that, looking at the LDL particle size becomes important. I've had people that had familial hyperlipidemias. So they had familial, genetic polymorphisms that led to their LDL cholesterol being in excess of 200. And they had very large buoyant LDL particles. And with those patients, I always scan them. I do a CLEERLY or a CT angio to take a look at their arteries. Controversial, but for me, I'm trying to keep people alive for as long as possible. So I get that baseline scan for them. And lo and behold, they'd be in their 40s with these large buoyant LDL particles, like in an ungodly high number, and their arteries would be okay. They didn't have that much soft plaque because they had buoyant LDL particles, right? I've had other patients with kind of small to normal size familial hyperlipidemias with LDL, and I've had to send them to bypass it. The youngest was 31 years old, needed a 5-vessel heart bypass. So I think that looking at LDL alone is not, at least in 2025 when we're recording, is part of the equation, but it's not the end of the story, right? It's like when you're like my kids, I mentioned I have daughters, they say, oh, I'm going out, right? That would never be a sufficient statement, right? Who are you going out with? Where are you going? Are there guns and drugs and this involved? Does the person driving you have a criminal record, right? There's a ton of follow-up questions that need to be asked, right? So similarly, like with the LDL particle, with the regular lipid panel, I think there's so much more now knowledge that we have and so much more testing that's more available for us to get a more complete picture of what's going on with our patients and our clients. And so looking at ApoB, LP(a), all of these then kind of add into the tapestry and the mosaic of that person as an individual for me to be able to say, okay, you know what, your LDL is low, which is good, but your LP(a) is high. So we still need to do this, right? Or the other, or getting back to if diet isn't the source of cholesterol, where is all this cholesterol coming from? Well, LDL can be an acute phase reactant, right? So, maybe there's a ton of of inflammation happening somewhere. There's, vascular inflammation. Maybe there's glycocalyx injury. Maybe there's toxin exposure that you don't realize, right? Maybe there's chronic mold. Maybe there's some ongoing smoldering chronic bacterial infection or viral infection that's at play here, right? I mean, we have to look beyond if I lower LDL, people get better, which is what the conventional model kind of thinks. And again, I think we're right for the wrong reasons, but we're not getting to the why, right? Why is cholesterol high? What's beyond? If diet isn't the cause, then what's the deal? And so that's
why
where
is the body making it?
Yeah, exactly. And that's where the cardiometabolics comes into play, insulin resistance and looking at all these other metrics, because once you start to improve that, then kind of these energy blocks get unstuck and then the body works the way that it should, right? So, I can't say that happens in everybody, but I certainly know in me as my N of 1, as I started to improve my body composition, lift more weights, eat fewer, processed foods and all that stuff. I mean, I'm not saying I got back to normal because genetically I'm cursed, but, I was able to go on a much lower dose of statin. And yes, I'm on a statin. As a cardiologist, I feel that it's important for me. It's a personal decision. But I know that I'm doing what I can do to look at my numbers, look at my risk, and reduce things as much as possible.
Yeah. Well, I mean, so you bring up the next hot topic. So first of all, just to recap a little bit, when it comes to cholesterol numbers, what you're looking at, Matt, it's the details, the devil's in the details.
Exactly.
On the cholesterol numbers. You've mentioned LP little a couple of times. Maybe explain to the audience who are not familiar with LP little a what it is and what it means. Yeah. And then we're going to dovetail into the dreaded statin discussion, because it's another, but you know what I mean?
It's emotionally charged. So LP little a, we can hit that one pretty quickly. So as I mentioned, on the surface of these LDL particles, we have a ton of cell surface proteins. They're receptor ligands for LDL receptor and ApoB and all these things. And one of them can be this lipoprotein little a, it's called. And essentially what that is, it's a structural protein. So imagine this is just a blob of jelly floating around. So you have to have proteins to give these cells structure. So it's a structural protein, but it significantly increases the atherogenic risk of that particle. So it's like taking something bad and making it worse, right? So it's like, what is it? Like, riding on a motorcycle and then tearing off the sleeves of your leather jacket, right? All of a sudden you look more like a badass, right? So it's kind of like that for these LDL particles. And it's something that's been around in the literature for a while. It's probably been known about for 20 years or so, but just now we have these commercial assays available. And the remarkable thing is that it's a genetic mark of cardiovascular risk. So you can have somebody with a low LDL, but has a high LP little a, and they're still at risk. Famously, that personal trainer on The Biggest Loser, I can't remember his name, but he had a heart attack. This is someone in the prime and working out and all this stuff, but he ended up having a high LP little a unknowingly, right? So now we're seeing, and about 20% of people in a general population will have an elevated LP little a. In African American populations, it's about 50, so specific to their group. So I think it's an important marker to assess. Generally speaking, it's a one and done. So you just check it once and it'll be elevated. There are, some medications now out. Probably phase 3 or phase 4 clinical trials. A couple were reported at the American Heart Association meeting last year that show a reduction in LP little a, so a therapeutic for it. We don't know. They're like these antibody medications. Like I can't remember the name off the top of my head.
It's not the SGLT.
SGLT2 is a different medication. Yeah, that's for diabetes and stuff. That's or you may be thinking of the PCSK9 inhibitors. Yeah, those are injectable. Those work to help prevent the degradation of the LDL receptor. So you have more of these hungry hippos on your cells. That's a different mechanism than this. But the point of that being is that there are therapeutics. We don't know completely. We're not sure with the outcomes data where it would be, the first step of any cholesterol medications like the PCSK9s was, number one, does it change the biomarker that you're looking for? So does it drop your LDL for PCSK9? Does it drop your LP(a) for these medicines? And number two, does dropping that medication have the intended or dropping that biomarker have the intended effect, right? Because we learned, I think it was in the 1990s or so, there's this ApoA Milano. It was some Italian village outside of Milan. These people lived forever. And so they learned that, they've got this special protein. Let's just isolate it and give people a ton of it and see what happens. And turns out you increase their ApoA Milano level, which is what you're looking for, but they also died faster, which that clinical trial was stopped, right? So not good.
Yeah.
So, now the outcome trials will come out. So there may be some benefit. The PCSK9 inhibitors, which are the genetic or the injectable cholesterol medications, do show a modest drop in LPA levels as well. So the point of that being is that, for most people, by and large, you just check it once and you're done. If you do have some elevation, you want to optimize whatever else you can optimize, and that may include being on a statin drug to reduce your statin. I think diet and lifestyle is certainly a big part of that. And then, wait to see what these new medications will show.
Yeah. So on the cholesterol, going back to the cholesterol thing, there's, one of the big fights is there are people who just simply will not, there was a study I read a long time ago that talked about, in elderly populations when cholesterols were too low, which they seem to be getting driven down constantly, like being driven down by the pharma companies. I mean, I don't know who, but let's just say it's pharma companies keep dropping what the threshold should be. But in people over the age of, I can't remember if it was maybe 80, people with the lowest cholesterol rates had the higher rates of depression and maybe even cognitive decline.
Yeah.
And so based on that, you have a big population of biohackers who are like, we need to keep our cholesterol numbers high.
Yeah.
And then you've got the other guys who are like, are you insane? You're going to die. We need to drop them down. So where do you think the nuance
is? Yeah. I mean, and this is a classic case of, cardiologists are from Mars and everybody else is on Venus, because when we look at these LDL trials and driving these rates down, we're looking at what's called MACE, major adverse cardiac events, right? So we're looking at, if I drop your cholesterol to -6, right, are you going to have a heart attack? And the answer is unsurprisingly. And again, like I said, I don't think there's a lot of discussion to be had about LDL and cardiovascular correlations, right? So at least in my mind. So these outcome studies are looking at driving these LDL targets lower and lower and reducing cardiovascular events. And they're seeing a reduction. And so, that is what the guidelines and societies are putting forth. But what we're not looking at are other outcomes, right? Like the signal for insulin resistance and brain and kind of all of these things. As you mentioned, the brain is like 80% cholesterol or some crazy amount, right? Or looking at hormones. And, if we've got hormones all have a cholesterol backbone, and now I'm dropping these the cholesterol particles super low, what's going to happen? Now, again, as I mentioned, most cells have the ability to synthesize cholesterol and are able to make the hormones that they need. So it's not that big of a deal. But what I will say is I think that cardiologists and the medical establishment in particular doesn't understand, maybe not we have a good understanding of the major adverse cardiac events that happen, but we don't understand like the nuisance things that happen to patients, right? And the literature doesn't really point to that too much. So there may be a concern about memory loss, right? And so there was a database looking at, I think it was the ALLHAT patient database, looking at a hypertensive trial, but they looked at brain outcomes in these patients on statin drugs, and they saw, no statistically significant difference, right? Is what they say. And so therefore there's no point, it doesn't make sense that statins cause mental decline, but no statistically significant difference doesn't mean there's no difference, right? And this is what the nuance of statistics is, that population-based statistics can't be applied to an individual, right? So if having an LDL of 160 puts somebody at a 63, and I'm making that number up, 63% risk of a heart attack, that doesn't mean I have a 63% heart attack. I'm binary, right? I'm either 100% or 0 for my cardiovascular outcome, right? And so this is where we have to be kinder and gentler as we look at clinical trials, is to say, okay, maybe in aggregate, people do okay, but there's never been a 100% zero outcome of any clinical trial as far as I've known, meaning that if you don't do an intervention XYZ, 100% of people get it. And if you do the intervention, 0% of people get it, right? So now what we're doing is throwing the baby out with the bathwater. We're taking people who are potentially seriously suffering from whatever outcome, back pain, shoulder pain, brain fog. I remember when I took a statin called Simvastatin or Zocor, I got weird trippy dreams, right? And so we're not taking that into account for people and saying, okay, you know what? This is real. This can happen. And, there's this famous study that was done that people were put on a statin versus placebo, and the placebo arm was higher in terms of reported adverse reactions than the statin arm was. And so that was taken by most cardiologists to say, oh, people are just making this up. come on, like a patient doesn't have something better to do than complain about something they're worried about. And if they are worried about something and it's not your drug, you still got to figure it out, dude. You can't just be like, go to hell. You know what I mean? Like, it's nonsense.
Doesn't fit the narrative.
Nonsense. Yeah, exactly. Yeah. You don't fit my evaluate or my algorithm, what should happen, therefore you're wrong. No, it doesn't make sense. And so, so in this world of statins, there are camps of people who will have LDLs of 200 and say, I will never go on a statin. There are people who have LDLs of like 30 and say, I'm taking a statin every day. In fact, I'm just, crushing up the tablet and snorting lines of statin. I love it so much. Right. So you have these two camps. And I don't think, and I mean, honestly, it's not a cop-out answer, but, I think what we have to do is take into account the belief system of the patients, right? Take into account where they're coming from, why they're saying these things, help them understand the science a little bit more. So if someone is like I want to get my cholesterol down to -10, okay, understand, like you are an extremist in that standpoint. Let's talk about what this actually means. Or if you are I sneeze and a blob of cholesterol comes out of my nose, but I still don't want to go on because my levels are so high and I still don't want to go on a statin. Okay, why are you coming at that? Help people understand the risk. I think either way you optimize diet and lifestyle, right? Nobody can argue that. And then, see, is it a block of being on a medication in general? Is there something about a statin? Because now we have several lovely statin alternative drugs, injectable and oral and otherwise, that can be used. So is it just, the depletion of coenzyme Q10 that you're worried about, the back pain, the muscle, and I'm a power lifter. So there is a study that shows that being on statins can lead to a 10 to 12% decrease in muscle function. So for most people, it's not a big deal. But when I'm squatting 400 pounds, that's a difference between 360 and 400, which is a huge deal, right? So is that what the block is? Like, where are we coming at this from? And again, you're never going to win a debate, right? You're never going to win when people are so zealous about whatever side they're on. There's very little that I can say that's going to change their mind, right? But you have to kind of let them know, okay, I see where you're coming from. This is where I'm coming from. Doesn't make sense to you. And I will say this, people might think, oh, Sanjay's pro-statin. I'm not pro-statin. I'm just anti-stupid, really is what it is, right? Because on the flip side is that we use too much statin medication. Like, so in our universe, there's this, in the statistical kind of approach to medicine and literature, there's this number that we calculate called the number needed to treat, 1 over absolute risk reduction, right? Basically what that is how many people do you need to treat to save one life? Very, altruistic and great metric, right? And so when we look at heart failure and medications for heart failure, it's like 1 in 30 people. When we look at dialysis, which is the benchmark, I think it was 1 in 25. You do 25 patients on dialysis to save 1, right? That was the Medicare benchmark. But when we look at primary prevention for statin medications, oftentimes that number, depending on the study and the population, is anywhere from 1 in 90 to 1 in 200. Which, sounds less efficacious. But then when you flip that statistic and say, all right, so that means 89 out of 90 people who are on this medication will never get a benefit, right? That just means that we have to be smarter about our decision making, right? Or in, and so, I think that we have to look at this appropriately and say, okay, I get that you don't want to be in a statin. As cardiologists and as vascular specialists and Dr. B, you have to say, and you know what? I didn't think that you would ever get a benefit from a statin, right? Or you may never get a benefit from a statin. But let's do a CLEERLY scan. Let's see if you have soft plaque. Let's look at your cardiometabolics. Let's look at your insulin level. Let's pop you on a CGM. Let's look at your hemoglobin A1C. Let's look at your C-peptide. Let's look at these other markers of metabolics and vascular inflammation. Let's look at cholesterol degradation products and see, are you an overabsorber or are you an overproducer and change things that way, I mean, there's so much more that can be done. So, I guess I am, like I said, I'm very much pro using all the tools at our disposal to have a much sharper indication for a cholesterol medication. And I will say that now, unless it's in what's called a secondary prevention setting where somebody's had a heart attack or had a stroke or had heart bypass, or I've had to fix their lower extremity arteries or something, I'm much more deliberate about that statin conversation. And in fact, there's a great tool put out by this really funky, place you may have never heard of called the Mayo Clinic.
Yeah.
That it's called the Mayo Clinic Statin Decision Tool or AID or something. Just Google it and you can plug in your numbers and it'll show you a real pictograph of what your benefit would be. And it'll say, I mean, most of the time when I plug it in and show it to patients, it'll say, given your age, your gender, your blood pressure, and your cholesterol numbers, 4 out of 100 people may get a benefit out of this, and so then it's up to that patient to decide, or me to have that discussion with them. Do you think that you're one of those 4 people or one of those 25? What are the other things that we can look at? Let's get testing. Let's do a CIMT and see if there's something brewing, right?
Exactly.
Let's look at,
you start to dig. Yeah.
So then you dig deeper. And my favorite thing to do is, I worked in a healthcare system where we had all their x-rays and CAT scans available. I'd pull up an old scan that they may have already had and look up and down the vessels and say, hey, you know what? On the scan that you had 2 years ago for your belly pain, which you probably didn't need to scan for your belly pain, but that's a whole other thing, is that I see evidence of, calcification in your abdominal aorta. You know what? That puts you at a higher risk. So, we don't need to use more testing. We can just use the testing that we've had to further risk stratify.
Yeah. No, I think that's so interesting. Okay. A couple of questions. I know you got to go. You have a presentation and there's 20 questions I want to ask you.
Oh, no.
Quickly, I'm not going to ask all 20. You mentioned that there are better statins. Do you want to just rattle off like the statins that people maybe should ask their doctor about?
Yeah, I think the 2 that are probably the ones that should be used the most right now, atorvastatin, used to be brand name Lipitor, and rosuvastatin, brand name Crestor. Both of these are available as generic. For people who are on a lot of medications or have had muscle aches and pains, still around is something called pravastatin. It used to be called Pravachol. It's metabolized a little bit differently, more through the kidney. It's more water soluble. So it tends to be that people get less of the aches and pains. Now, the trade-off for that is that it's less potent. You'll need a higher dose to get the same effect, but it's still around. So I think those 3 are really the only 3 that should exist in my mind.
Right. Because the pravastatin, would that make it more appropriate for someone who, your patient who's got LP(a), very active, kind of an athlete?
Yeah, I mean, I would
don't want to compromise their athletic performance.
Yeah, I mean, I would. If there's a dose response to the side effects, so I'd probably put people on like a low dose rosuvastatin. If that's what it comes to. But again, it would depend on the numbers and so many different factors.
Yeah. Okay.
But that's
there's
where
options and different outcomes.
There's options and there's non-statin options, as I mentioned as well. So
okay. Can plaque be reversed?
Actually, yeah, with aggressive LDL control, there's some studies that it can. I think that part of that is diet and lifestyle intervention. So, so the funded, I'll say it this way, is the funded clinical trials showed that high dose of rosuvastatin and some of these injectable PCSK9 inhibitors, so 3 or 4 papers on this, can lead to reduction in plaque volume. So you can reverse it. I suspect that diet and lifestyle interventions, reducing inflammation, optimizing health, getting rid of insulin resistance, can also do that. Nobody's paying for a clinical trial of broccoli versus placebo, but I think mechanistically it makes sense. And in fact, that's what this next chapter of my career is based on, right? So I hope it works.
I love it. All right. So if you could prescribe non-medical habits for a healthy heart, what would be at the absolute top of the list?
Sleep, 7.5 hours at least of sleep a night. People don't realize that, right? So not so much movement, but sleep is huge for brain health, for vascular health, for cardiovascular, all the things.
Yeah. And sleep quality, I would think, because the other big caveat in sleep is the mouth breathers. What actually, speaking of which, what are your thoughts on mouth breathing?
Yeah, I mean, so you're reducing, part of the benefit of nasal breathing is you're increasing nitric oxide, NO. NO is a potent vasodilator. You don't get that through the mouth. I actually suggest mouth taping to people quite a bit. So you take a piece of paper tape, go up and down when you sleep, and people are surprised that their blood pressure responds to that as well. It can be a little bit, if you've been a boxer and you have a hugely deviated septum or something, then you have to be worried about it. But as long as you have normal nasal passages, people say my nose is plugged up all the time, but when you actually have to nose breathe, it opens up. When I was early on in my mouth taping experience, I did a Peloton with duct tape across my mouth. I didn't realize that I wouldn't be able to drink water, but I made sure I breathed through my nose, and my nasal passages were never more open than they were at that time, both of them. So don't use duct tape. Bad idea. Yeah. Particularly in a 45-minute Peloton where I was dying for thirst, but it was just one of those mental things where I was like, you know what, I just need to give this a go. Like a stupid sufferfest nonsense, not like our buddy that walked across Antarctica, but a stupid little mini sufferfest thing. But yeah, I think that nasal breathing is huge. If you can do a mouth tape, you'll see blood pressure responses and all sorts of different things. Okay.
A couple of quick fire questions, and I'm going to let you go because we never got to the diet conversation, which I really wanted to get to.
Well, we'll have to come back.
We will absolutely have to come back and do a part 2. But if there's a food to avoid compromising heart health, and if there's a food to eat.
Well, I think in terms of foods to avoid, I mean, I hate to be generic, but any ultra processed, so anything, I kind of think of it in Ayurvedic terms, anything that doesn't have prana, anything that doesn't have a life force, right? So,
Yeah.
so ultra processed, anything that won't spoil, basically. It was,
Yeah.
is kind of like you are adding to your life by taking on the life force of what you eat, right? It's kind of a weird way to think about what I eat every day, but it works for me. And so, the ultra processed foods, our body doesn't know what to do. I mean, I would think, anything that comes in a foil bag or a box is basically something. Yeah. If we're looking at the worst things, Skittles have been shown, the candy Skittles, to have the highest glycemic impact. And they're full of, as of right now, they haven't taken out all the artificial dyes and things. So I think that's probably the worst.
What about deep fried foods?
Yeah, I mean, deep fried foods, grilled meats, like all of that stuff, I think, are horrible. Anything that you can get at a county fair, probably is to be avoided, right? Like deep fried butter sticks and all sorts of craziness like that people get at those fairs. In terms of healthy things, I think it's stuff that your body is designed to eat, right? So I go straight to like broccoli and the cruciferous vegetables. I think they are not just healthy foods, but healing foods. Sulforaphane, eating 5 colors at every meal, right? Getting the phytochemicals in. I don't think that extremes of diet, and this is something we can talk about maybe in our next, but like carnivore, vegan. I mean, I'm much more of a balanced person. We have, all these different types of teeth. We have incisors and molars and all of these things because our bodies were designed to eat different things. And so, finding a happy medium, and that's what I preach in the program that I run, is that it's not all of this or all of that. It's some of this and some of that. And that's why I'm not super popular online, because when you're moderate, nobody cares. You have to be, no, you got to eat all, all fish eyes. You have to eat all, liver, all this, all that. And our bodies were just not designed to do that. Right. So, so I think in terms of the single beneficial heart health thing would be, the cruciferous vegetables. I love those for a lot of different reasons. Beets are great. You have to be cautious about sugar, but they do have a lot of, precursors for nitric oxide, which is another great thing. High magnesium containing foods. All basically it's like the stuff your grandma told you to eat, right? Is really kind of, it's grandma wisdom. I call it, is really just going back to the natural stuff that your body was meant to eat.
I love it. Thank you. But not excluding meat, fish, and chicken. So
no, I think that,
to be clear, guys.
At least in my mind, is that while, being plant forward is definitely a good idea, you don't necessarily need to be plant exclusive, right? So I think that there's definite benefits to proteins, and the right proteins. Don't sit here and eat a hot dog and tell me that meat is healthy, right? No. But eating grass-fed, grass-finished, not, if you eat fish, watching out for the high mercury fish, being cognizant of the mercury load, even in chicken, like antibiotic free and happy chickens and all that stuff, it makes a difference, because we are what our food ate. So if you're eating inflamed food, that's going to inflame you, right? And I think that's where a lot of these meat-based clinical trials can go wrong, is that they're not looking at the proper foods to be eaten. And so we're eating inflamed foods and we're getting signs of inflammation. Yeah, that just makes sense. You know what? If you eat a bad banana, you're going to get sick, right? Like that's
it's just the way it works.
It's just like I said, I'm anti-stupid, I guess.
I love it. Well, Dr. Sanjay, I have a whole other list of questions for you. So clearly we're going to need a part 2. Thank you so much for your time today. This has been really great and eye-opening. Why don't you let people know where they can find you, and for those who are interested, how they can learn more about your program?
Absolutely. So you can follow me on Instagram, which is my primary social media route, at Dr. Sanjay MD. So DoctorSanjaymD. In fact, it's right there on down there. And if you want to learn more about working with me, you can go to www.lagunamedicine.com. That's my practice. I run a health and wellness program online, so anywhere around the world, called Well 12, a 12-week program that really kind of focuses on mental, emotional, spiritual, diet, sleep, stress, all of the 12 elements of wellness that are outside of just lab tests. Or I'm taking on private patients as well. So if you want to work with me one-on-one and you're a state where I'm licensed, we can take that on as well. But it's just great. And really my purpose in life, I tell people my midlife crisis is to try to heal at scale, right? And really kind of doing diet, doing lifestyle interventions, so powerful. And if there's one takeaway I wish anybody had from our time today, it's just that you can change the narrative. It's never too late, and it doesn't have to be a pill, right? That's what I want people to know.
Thank you. That's amazing. Thank you so much. This has been fantastic.
Awesome. So great to be here. Hopefully I can come back soon.
Absolutely.